Hi everyone. Again, this is the second part of our lecture for week 10. In the previous one we talked about culturally competent nursing care. Now I'm going to be talking to you about nursing in our healthcare delivery system. I also wanted to mention quickly before I get started that I also did post in this week's folder, week 10, a practice quiz for you guys as well. And this has to do with questions relating to last week's content on managing change. And then also there's some questions on culturally competent care. So just some practice questions for you guys to kind of see what may show up on the exam in a couple of weeks, just to get you practicing. All right, so here we go on the healthcare system. So the objectives for this lecture are we want to identify changes in the healthcare that affect nursing in the United States, and there are many of them. We want to identify issues with healthcare cost, and we want to be able to describe healthcare economics and the impact it has on nursing. So again, definitely a hot topic that was just brought up with the midterm elections. What are we going to do about our healthcare system? So I'm going to kind of go over what is in our healthcare system. We're going to look briefly at some of the other healthcare systems within different countries, but I want to focus mostly in the United States. So some of the challenges and opportunities, again, that we face, and we can go back to Healthy People 2020 with this, is we have a commitment to high quality care. And we as nurses need to be able to find ways to provide that high quality care. And unfortunately, with the use of fewer resources. With healthcare budget, costs are high, and cuts to our budget and things like that are always going on. So we need to find ways to find high quality care to our patients or provide that care with fewer resources. We need to find ways to avoid that undue stress and burnout. We talked about that in the second week of nursing, or of this class, how nursing can cause that undue stress and burnout. Traditional values are at stake, such as client advocacy, holistic care, meeting healthcare needs. And there is nothing more frustrating than when I used to work at the clinic and a patient would be on a medication that was working for them. They absolutely were doing so good on it. Their symptoms were improving. And then all of a sudden their insurance company would say, oh, we're not covering that med anymore. Change it to this one. Some patients choose to pay the expense out of pocket and some can't. So we need to find ways to provide that high quality care, but our traditional values are at stake. And we are in a position to create new roles and redefine nursing through healthcare. So let's kind of talk a little bit, go into a little bit more detail about our healthcare system here. What are some changes in healthcare? Definitely some changes we are seeing relate to demographics, populations, economics, demographic changes for sure, increase in life expectancy. We have people who are living longer, healthier lives because of the technology and because of the, resources that we do have. But we also do have a larger segment of older citizens that are 65 and older, which means we have an increase in chronic illness. So we need to be able to control costs in that way. So we have people living longer lives and who are developing more chronic diseases because they're living chronic lives. Some people are healthier, but some people, the majority of our older adults or geriatric patients have these chronic illnesses that we now have to take care of. Some economic challenges that we face, and we've seen an upward swing on this and a downward swing, economic downturns, unemployment, government and taxpayers end up gradually assuming a greater segment of the healthcare coverage. Towards the end of this lecture, we're going to talk about Obamacare, some of the positives, some of the negatives of it. And again, with these midterm elections, that's a huge topic. Do we switch to a market insurance plan like we used to have prior to Obamacare? Are we going to, switch to a government controlled? So there's all sorts of positive and negatives of each that we need to take a look at. And then we also have to deal with waste, fraud, and abuse in government programs. That's definitely increasing costs for taxpayers. So some healthcare cost issues, again, demand versus supply of healthcare. We have increased and expensive care. We have really good healthcare options, but sometimes they're very expensive. But we also do have patients in healthcare consumers like you and I that do have an increased demand for expensive care. We want these tests done. Unfortunately, insurances aren't paying for all of it, so it becomes very expensive. Increased cost of insurance, coverage in the private sector. I know for sure that my insurance costs have gone up huge since the enactment of Obamacare. And I don't know if staying in the private market plan prior to the initiation of the Affordable Care Act, if the costs would have stayed affordable or if they would have been going up. You never know. But we all notice it's a hit to our pocketbook, to our checkbooks. Healthcare definitely has been. Increase in costs result in diminished ability for consumers to afford care. So that's big because we do want that healthcare equity across the board for everybody. So paying for healthcare. We talk a little bit about paying for healthcare. We have in the past, private insurers have paid for U.S. healthcare plans, but then in 1965, the federal government entered into the healthcare financing with the passage of Medicare and Medicaid. So we were seeing that our seniors were not being taken care of. So once they retire, if they didn't have enough savings or they didn't, have any other type of insurance, who was going to help our senior citizens? Or for those that can't afford health care. So they enacted Medicare and Medicaid. So nearly half the cost of health care is covered by at least one of these two. It's a huge amount, billions of dollars a year. So again, I talked a little bit about how there's a debate about national health care versus private insurance. And then most industrialized nations have some sort of national health policy that provides financing for care. You see Canada, healthcare for all. So what is right? What is going to work for the United States? That's still up for debate, and all of us have our own opinions on that. So what are some cost containment strategies that we can use? There's many things that nurses can do to help with healthcare costs. We need to be aware of some of the resources that may be limited as a result of healthcare delivery. They enacted the use of more assistive personnel, such as CNAs. So the nurses weren't taking away from the tasks that they should be doing. They initiated more of these CNA roles, LPN roles, things like that, where nurses could perform the tasks safely and effectively and delegate these tasks that can be delegated to personnel that could be paid less per se. So we're not going to pay a nurse, $40 an hour, for example, to do a CNA job who could get paid, a lot less than that. So that's kind of one way that they, have some cost containment strategies, is let's hire people for less money to do work that the nurses were doing, but they don't have to. They're tasks that can be delegated. However, I don't want to undermine our CNAs and other personnel because they are all extremely important in our healthcare system. Access to healthcare. Why are there barriers to healthcare? They're pretty obvious. Cost of care for sure is a big one. People don't go to the hospital because they can't afford it or they don't want that huge bill. Again, I remember one of my home improvement projects gone wrong. I ended up in the emergency room and I ended up getting stitches because I cut my hand open trying to remove some carpeting from my house. And just to walk in the door, they charged me $1,000. That wasn't even any care rendered. That is just to walk through the emergency room door. So I got a call from the financing department asking me why I didn't pay this. I told them I'm waiting for my insurance to cover it. They said, nope, your insurance is not going to pay for this. This is the fee for just using our ER services. I was just baffled by that. Ended up paying it out of pocket. And then, of course, there were additional costs that came with the actual services they provided to me. So cost of care is just hugely expensive. People with lack of insurance, problems with insurance, difficulty getting appointments, difficulty finding the services they need, lack of transportation. I know difficulty getting appointments, that is a huge one going on in our healthcare system. I had to wait one time 6 months for an appointment. In complete misery. I was trying to figure out what I was allergic to, and I was, itching everywhere, and, I was trying to, change my detergents and change everything like that until I could find out what I was exactly allergic to. But ended up waiting 6 months to finally see a doctor so they could do testing. So, I mean, and I think that's ridiculous. We got patients who are suffering and it can't get in to see a physician. So definitely a lot of barriers to accessing healthcare costs or healthcare services. So as nurses, we want healthcare to be cost effective. Again, I talk about community based, and I know I told you, you are going to hear me say this over and over and over again. We are switching healthcare from the inpatient setting to the outpatient setting. We want to get ourselves healthy, our patients healthy, so they are not admitted back into the hospital. So keep it in the community setting. Access to healthcare is a basic human right. Everybody deserves healthcare, and it should be affordable, available, and acceptable. Okay, just because it's a lower plan doesn't mean it should be any more important than a person who can afford a higher plan. Case management, I'm not going to spend too much time on this, but case managers, I know we talked about case management, and the key word with that is coordination of care. They are a huge part of our healthcare system. They help with cost-related healthcare issues. They can be nurses, social workers, other healthcare professionals. Most of the time they're registered nurses who work one-on-one with the social workers and then collaborate with the nurses as well. But very, very important, keep the healthcare affordable for the patients, find them resources that they need. Very important job they have. Again, case managers are going to be able to intervene and link people to appropriate resources, services, community sources in the community or resources in the community. And they're going to assist with cost efficiency by avoiding or duplicating services and preventing gaps in service. Very, very good on follow-up of care, calling those patients, making sure they're getting their appointments in, linking them up with resources in the community, with services that they need so that they stay out of the hospital and in their homes and in the community. So let's talk about some different types of insurance. I'm not going to go into too much detail with all of these. I just want you to get a basic understanding of what's out there. Your textbook goes, the chapter for this week goes into, a good job of talking about the different healthcare costs. It's chapter 7 and the different plans that we have. And I will point you out to some certain pages in the textbook that have some interesting information on them. So the federal government, again, is the biggest consumer of healthcare. So we talked about the initiation of Medicare and Medicaid. Medicare specifically is for patients who are 65 and older. Medicaid is for people who are, I believe, 18 years and up to age 65. If they're less than age 16, we usually have like a Badger Care, which is a type of Medicaid, but they usually fall on a slightly different type of insurance. Medicare has more of what we call a prospective payment system. We have DRGs, which are diagnosis related groups. And what that means is that hospitals are going to receive a set dollar amount for each patient based on their diagnosis related group. So for example, you have a patient who comes in with diabetes who's on Medicare. Medicare is going to say, okay, for a diabetic patient, I'm going to give you this much money to treat them. They're going to give that to the hospital. So the hospital's goal is to treat the patient for less than what Medicare is giving them so they can turn around a profit. So I hope that kind of makes sense to you. So a patient with diabetes has a separate DRG. A patient with heart failure is going to have a separate DRG. And all that means is that the hospital is going to receive a set dollar amount for that specific diagnosis for that hospital to treat them. And again, if the hospital can make a profit, they're going to treat that patient for less than what the Medicare is giving them. We have out-of-pocket payments, and this is people who have no insurance. So the consumer, you or I, or our patients are going to pay directly to the provider for services. A lot of times they knock off 20%. So if you go and see a doctor and they say, okay, you owe me $225 today, mine we're going to knock off, 20% because you're paying it fully up front. A lot of times they will try to do that for patients. Private individual insurance. This is where we see insurance premiums is paid by the individual consumer to an insurance company. So this is usually is not related to an employee sponsored type insurance. So this might be an insurance that you purchase on your own, and then you pay right to the insurance company. The insurance then turns around and pays the provider, but it can be very, very expensive. Individual private insurances can be very, very expensive because you don't have the employer who's paying part of that for you. Healthcare savings accounts, these are wonderful. They were created in Congress in 2003. So it allows individuals to pay for selected healthcare expenses with pre-taxed dollars. So you set aside a certain amount of money in your paycheck for this healthcare savings account, and then you can use that money for, different expenses like co-pays. You can pay it for certain prescriptions, over-the-counter medications, sometimes Band-Aids, different things that you can use for this healthcare savings account. But again, a selected amount of pre-tax dollars is put aside from your paycheck every week or 2 weeks, however you get paid. Employee-sponsored group insurance, this is what we see the most. This was developed during the Great Depression and really expanded after World War II. What was happening is there was, a freeze on wages because, a lot of the men were out working after World War II. With the Great Depression as well, there weren't a lot of jobs available. They couldn't offer their employees higher wages. So a way to get them into their employment was to offer benefits. And so they started offering health insurance. So basically, unlike the private insurance, you're going to still pay a portion, but your employee is going to help you pay that premium to purchase health insurance. Managed care. This is something you'll hear a lot about. Managed care focuses on health maintenance and primary care. So basically all your care is provided by your primary care physician, and then usually you'll need a referral to access a specialist and a hospitalist. So this is more like your HMO type care, where in order for you to see a specialist or to go see a second opinion, you have to have a referral by your primary care physician. Otherwise, they do not cover it for you. And then we have PPO, so that's more of an HMO. Then we have a PPO, which is a preferred provider organization, which is a contractual agreement between a set of providers and insurance plans. So we have comprehensive health services that are at discount to companies that are under that contract. So a lot of the insurances that employers purchase are PPOs. So on page 139 in your textbook, there is an interesting table, table 7.2, that talks about the different healthcare coverage. So it breaks it down, if you look on that left-hand column, by sex, nativity, region, household income. And it talks about total covered, not covered, some covered. It talks about the percent covered by private insurance, employee-based insurance. And it kind of goes, it's a great graph to kind of see the differences in there. So I encourage you to take a look at that table on page 139. Don't memorize it, please. I'm not going to ask you direct questions on what percentage of people were covered by private insurance, in the Northeast region. I'm not going to do that. It's just an interesting table for you to look at. I have a video here that talks about healthcare in the United States. It's about 7.5 minutes long, so I encourage you to watch it. The gentleman in the video breaks down the differences, our healthcare system basically, in 7.5 minutes in the United States. He's kind of an interesting guy to listen to, gives his own little 2 cents on it. A little comical video. So just kind of take a look at it. Again, it's very informational. Tells you about our healthcare system in 7.5 minutes. Some international perspectives. I just want to talk a little bit about what other healthcare services are available around the world. So we have, different types of insurance plans that we see. The biggest one I think we hear is about Canada. Healthcare for all. Government ran. So we're going to kind of take a look at the different types. So we have 4 categories of healthcare. Excuse me. The first one, socialized medicine. So this is basically where the state owns and controls production. Physicians derive virtually all of their income from the government. And you see pretty much socialized medicine, and I gave examples of countries, the UK, Sweden, and Denmark. The next one is socialized insurance, where again, we see this in Canada, France, and Australia, where all medically necessary services are covered, including physician care, hospital service, and some prescription drugs. So this is, again, health insurance for all. It's covered by, the government. We have mandatory health insurance, where we have large nonprofit health insurance organizations, or what they call sick funds, are usually organized around large employers or work-based associations. These government-sponsored programs cover citizens who are not part of this fund. So they have this big sickness fund that they draw from, but if you're not a citizen, or I'm sorry, if you are not part of the sickness fund, then the government sponsors you. Sorry, kind of getting that, and I want to make sure you understand it in a way. And we see this in Germany and Japan. So again, they're large nonprofit health organizations. They call them sickness funds, and they're usually organized around employees or work-based associations. But if you have someone, let's say, who doesn't work, then they're covered by the government. Voluntary insurance. Now, I put United States under here. It's really hard for us to say we're kind of voluntary. We technically still are, and I'll kind of talk about that in a minute. But voluntary insurance provides no guarantee of universality. It's significant proportions of the population are still uninsured. So United States was always pretty much a voluntary insurance, system where you didn't have to get insurance if you didn't want to, if you couldn't afford it. The Affordable Care Act came along, kind of changed all that, where they pretty much made health insurance to be mandatory. And many of you will see on your tax returns at the end of the year that you have to show proof now that you have insurance. So whether we want to say the US is voluntary or not is still kind of gray area. There are many people who still choose not to take the insurance because it is cheaper to pay the fee on their taxes at the end of the year than it is to pay a premium all year long. So you can kind of decide what you think it kind of is. It's still, the book kind of categorized it as a voluntary insurance, but, and that's kind of changed along the way with the Affordable Care Act. So it's still I think it's kind of in between the two. We still are supposed to be required to get it, but many of us don't because it's expensive. So nursing economics, a few things. There are a few efforts made to determine actual costs of nursing care. And what does that mean? So nursing care is usually included in what they call the room rate, or the hospital bill. So you get a hospital bill and you will get like what it charged you to stay on that unit or in that bed for each night. And that's usually where nursing is included in. So they don't take into account the countless hours that we work to take care of our patients. We're kind of included in that overall bill. So every patient doesn't require the same amount of care. So it's kind of hard to actually determine what the hospital cost should actually be, and that's where we can see where things can be unfair. Maybe one patient required more of our care, tons of our care, but they're still going to get, charged, the same as the patient who maybe didn't receive as much of our care. So both consumers and healthcare professionals have concerns about the diminished quality of care. And this diminished quality of care can result from cost constraints, again, early discharge. Patients being discharged too early only to come back again. And it's a vicious cycle because patients who are on Medicare, who are discharged, let's say they have a diagnosis of heart failure, they treat them, they go home, they come back in less than a month, now Medicare is not going to reimburse that hospital because they're saying, okay, you didn't do your job. So we're trying to get patients in and out as quick as we can, treat them based off their insurance, but early discharge can also be, an economic downturn because now we're not going to get covered because that patient is back in the hospital again. Nursing shortages, huge issue. and then increase use of unlicensed assistive personnel. Again, I talked about that in the beginning of lecture, how we use this as a way, to cut costs, have a nursing assistant do a job that, for far less than what the nurse could do, but safely. But still, I think there's that concern about the diminished quality of care from us overusing some of our UAPs or CNAs or LPNs, things like that. Now we're going to talk about the types of ownership, financial ownership in the United States. And if you turn to page 125 in your textbook, kind of gives an overall graph. I think it's figure 7.1 on the different types of payment systems or ownership in the United States. I'm going to briefly go through them. First, we have public, which is federal, state, or local government owned. So they provide care regardless of client's ability to pay. So some of our county hospitals will do that, like Freighter. I believe they have to accept everybody in the ER, and regardless of their ability to pay. Private for-profit, so these are owned by private investors who want to make profits. They primarily serve paying clients and provide limited charitable care. So a lot of these private for-profit are going to be people who don't accept such plans such as Medicare, Medicaid, things like that. They're primarily paying clients who have good insurance, that type of thing. Private nonprofits, this is probably the most common one we see, owned by voluntary board of trustees, and they provide care for both paying clients and those who require charitable care. So again, this is what we see mostly in the United States. Pretty much everyone's going to get the care they need. Again, most hospitals in the United States are either public or nonprofit. They operate according to mission statements, and they receive tax exemptions based on their benefits to the community. A lot of times you go online, Aurora, Freighter, Pro Healthcare, whatever it may be, and they'll have a mission statement that they follow. When you get hired into these organizations, you'll see their mission statement, their philosophy of care. So that's kind of the way they operate. Some types of healthcare services that you'll see out there, all sorts of them, not just hospitals. We have clinic and outpatient care centers, psychiatric facilities, which in my opinion we need more of. Psychiatric care is falling through the cracks in our healthcare system. Home care, rehab facilities, long-term care facilities, long-term care, assisted living, hospice, and then respite care. Those are all different types of care. And those that aren't familiar with hospice care is for patients who have a terminal illness whose life expectancy is 6 months or less. That's when they qualify for hospice care. And then on pages 115 to 116 in Chapter 7, they talks a little bit about the Affordable Care Act. I'm sorry, Chapter 6, 115 through 116 in Chapter 6. It talks about the Affordable Care Act. So you have Table 6.4, which basically gives you the different components of the Affordable Care Act. And then table or box 6.2, which gives you some of the key provisions. And I think some of the key points of the Affordable Care Act were, first of all, it took away pre-existing conditions. It accepted pre-existing conditions, which was fabulous for people who had like diabetes or came in with cancer or different diseases like that. I remember my ex-husband was a diabetic. And when I first married him, he, not on my insurance, that was before the Affordable Care Act, my insurance would not pay for any of his diabetic related care until 1 year. So for a full year, we paid out of pocket for his doctor visits, insulins, any other medications he was on, labs, everything. Big, big expense. And then once that year hit, they started covering the care for him. Also, extending coverage for young people up to age 26, maybe who were still in school, brought in Medicare Part D to cover prescriptions. So you can kind of read that table on the huge provisions that were made because of the Affordable Care Act. So take a look at those. So again, there are my references. So again, that's our healthcare system kind of in a nutshell. Again, I encourage you to watch the video, please, that goes along with this lecture. And the first lecture that we had Also, again, there is a quiz that I posted in this week's folder on the culturally competent care and managing change. I also will post the answer key that goes along with it, so please try out those questions as well. Please let me know if anyone has any questions on any of these lectures, and I'd be happy to answer them for you. Otherwise, I will see you guys next week with your Healthy People 2020 projects. Again, any questions, let me know. Otherwise, you guys have a good one. Thanks.